Thank you for joining us this afternoon. We have a lot of material to get through in a very short period of time, so we included in our slides today a lot of information that you can take back as a resource in your office to review. And we included here the slide, the website where you can get additional information, including alerts regarding other industries that may be impacting the healthcare industry and all the COVID-19 information that we have been compiling at Morris Manning. As I mentioned today, we're going to go through a lot of topics because a lot of laws have changed or we've had waivers that have impacted what we do on a daily basis. And so as you can tell, we're going to cover a lot of topics, and I'm going to start with EMTALA and HIPAA, and then I'm going to transition it over to Bob Threlkeld, who's going to speak on the waivers. We had more waivers granted just this week. And then Elliot is going to cover telemedicine, the licensure and certificate of need, and fraud and abuse matters. And then George will provide us with updates on the funding opportunities, which I know a lot of us on this line have been focused on greatly this week with the Paycheck Protection and the SBA loan. So getting started with EMTALA, with regard to where we are at the virus and the epidemic or the pandemic and the national emergency that we're all addressing, our EMTALA obligations are not gone. I've seen a lot of information out there where they say, well, EMTALA's been waived, don't worry about it. But we still do have to engage with our patients when they present to our hospitals to perform that emergency medical screening. And for those patients that present that are concerned about having a COVID-19 diagnosis, whether they come to our emergency department directly on campus or if they arrive through an ambulance, we still need to perform that screening. And then we need to identify if they do have the symptoms to put them into isolation and conform with the CDC guidance. EMTALA has the obligation for all of us as healthcare providers to screen all the patients who present to our dedicated emergency departments or on our campus who appear to have an emergency medical condition. And we need to log them in and perform that emergency medical screening. If we are a facility that does not have the capacity, so we don't have enough PPE, we don't have enough beds, we don't have the level of acuity care staff to be able to provide care for these patients, then we have to evaluate a transfer. And if we're a specialized hospital that does have ventilators and negative pressure rooms and staff that have specialized expertise in infectious disease and pulmonology disorders, then in those areas, they would evaluate their capacity to accept more patients. I know this has been a hot topic for a lot of our hospitals over the last several weeks, just evaluating our capacity based upon what we have for personal protective equipment, our beds, our staffing, and the actual needs of the patient. So from an EMTALA standpoint, a lot of us on this line have set up different screening sites because we have patients coming into our emergency department with emergent conditions like a heart attack or a neuro issue, and they're coming to the emergency department. And so we've set up other screening sites to address the volume of patients who have the symptoms of COVID-19 and need to be screened and potentially tested. And under the EMTALA guidance, the government has said it's fine for you to have a screening location, and you can have one on your campus. Now remember, if a patient or someone presents on our campus and they are seeking for an emergency medical condition treatment, we have to do that emergency medical screening before we ask for registration. And the government has said it's fine to do the screening. If they show up on campus, we do need to log them in. And if you have set up a screening location that's still on the campus but not right at the emergency department, then you can direct them to that screening location, but we need to log them in first. Now, as of Monday, there was a waiver that if there's a state or emergency preparedness plan where there is a screening location that's set up off campus, as part of that plan, if someone arrives on campus just for a COVID-19 screening, we can direct them to that state or national emergency pandemic plan location for testing without there being an EMTALA violation. But if we go back for a second, if you're a hospital and you have a screening location on your campus and it's not part of the state or the local testing facilities, and let's say you've got a tent outside, you have nurses outside, they're going to do the screenings, and you want to put up signage so that people know where to go, you can do that. And I have a slide in a few minutes with the rules about that directly from the government. You can put up signage to say the screening will occur here, but you cannot put up signage that's going to discourage someone from coming to the emergency department. So we need to be very careful to make sure we're very clear. If someone presents on our campus and they're presenting for COVID-19 testing, that we do screen them under the EMTALA rules prior to asking for registration information. And then we also need to make sure that if we're doing screening locations on our campus and we're doing the medical screenings there, that we have qualified medical personnel performing the screenings. As you all know, under EMTALA, you're required to have qualified medical personnel, as defined by your bylaws, perform the emergency medical screening. So if you're engaging in an emergency medical screening for patients, remember to make sure it's staffed with the proper qualified medical personnel. I'm going to talk in a few minutes in more detail about how that can occur. And then off campus, if it's off campus and it doesn't have a dedicated emergency department, EMTALA does not apply to that screening location. So I know a lot of us have partnered up with the Department of Public Health, or we've partnered up with other community screening locations. Those are not governed by EMTALA if they're not on our campus and there's not a dedicated emergency department there. But we are required to make sure that if someone has an emergent situation when they're at that screening location, that we have some means of transporting them to the right site of service. So perhaps an ambulance or a paramedic being available. This is the slide I mentioned earlier about you're able to use directional signage, but please do not use signage that would prevent someone from presenting to the hospital's emergency department for an emergency medical screening and for emergent care. Now, from a screening standpoint, and this has been a big topic this past week with the growth of telemedicine that Elliot's going to touch on in just a few minutes, you can now use telemedicine for emergency medical screenings because the government has identified that in light of the spread of the virus, using telemedicine and using remote monitoring may be safer. The things to consider, though, that you don't want to lose sight of is when we deal with EMTALA cases, it's normally related to a failure to have an adequate emergency medical screening. So did you do everything you could have done for that patient based on the symptoms that they presented with? And then making sure from a capacity of the facility standpoint that if you have a patient and you have the right type of room, staff, PPE, and you can treat that patient, to care for that patient. And if you don't, coordinate with the Department of Public Health and the other providers who do have that specialized care to transfer that patient. And under the EMTALA guidance, the government said they'll look at the capacity of both facilities when trying to determine if everyone has complied with our requirements. And I've already mentioned the qualified medical personnel. So again, you can use telehealth for that emergency medical screening, but remember, we do have these other risk areas that we need to address to make sure it's done adequately. The other law that I don't want us to lose sight of, we talked about EMTALA and the need to do the emergency medical screening, including the COVID-19 screening, is HIPAA. We as healthcare providers or covered entities, we still have an affirmative obligation to protect the confidentiality and protection of our individual patients' information. So we can use it for treatment, payment, and healthcare operations without having to get a separate authorization. But there are some instances where we actually cannot disclose it without the patient's authorization, and that would be to the media. So I know a lot of us have worked on our press releases related to we have a COVID-19 positive patient in our facility or our community. We need to ensure that we are not including identifiers in the material that gets published to the media. Now, when you have to contact the Department of Public Health, which is required, you are allowed under HIPAA to disclose the information to a public health authority like the Department of Public Health or the CDC. And there is a mandatory requirement in Georgia, so I've included that here. In addition, the Department of Public Health and the CDC may be working with foreign governments and they may redisclose the information, but that would be under their guidance. The other area where you can disclose information is if someone else is at risk. So that's where we are working with someone else for treatment purposes. We need to identify to them that this person has been identified or diagnosed with COVID-19 as a positive diagnosis. So you are permitted to notify an individual if there's a risk to them, but the Department of Public Health is also an entity that can notify individuals. So there are different types of disclosures. There's the disclosure to the patient's family, and the way that should work, family and friends and people in the care plan, the healthcare provider should evaluate whether or not there is a reason to disclose to family members, friends, or others that are part of the care plan. And that healthcare provider should talk to the patient about that first if the patient has the capacity to make a decision. And if they don't have capacity, then the healthcare provider has to make that decision on their own. So it's important to refer to the healthcare provider as to whether or not information should be disclosed, and did we talk to the patient about it first, or did they have the ability to assist us in making that decision? The other key part, whether we're disclosing information because we think someone's at risk and they're treating the patient, or we're disclosing information to friends and family because someone has been diagnosed with it and they're incapacitated, or because the patient has said, yes, please tell my family so that they know what I need with regard to treatment, we should always try to disclose the minimum necessary information. So what is it that they need to know at that time to either prevent the risk of the spread of the virus, or to treat the patient, or to get the right resources to be able to treat the patient. So minimum necessary standards do not go away when we're in this pandemic. We still need to make sure that we're complying with the minimum necessary disclosures, and always refer to the healthcare provider in his judgment of who needs to be receiving information, whether they're at risk or if it's friends or family. There is also a HIPAA waiver included in the regs that have come out recently, and it's really related to the hospitals. When you implement your disaster plan, you are allowed to have a waiver of the privacy requirements under HIPAA, where we're supposed to ask a patient whether or not we can speak to their family, or if when you go into a hospital, they say, do you want to be listed in the directory, you opt in or you opt out. If you don't do that during your disaster plan, during the first 72 hours of it, that's not a HIPAA violation. Or if you forget to give them a notice of privacy practices because they're emergently coming through the emergency department, perhaps you're getting them immediately on a vent, everyone is taken up through the emergency department, we don't get the notice of privacy practices to them. If you're in your disaster emergency mode of operation in that first 72 hours, not completing that portion is not going to be a violation of HIPAA, and they will not enforce the penalties related to that. Same thing with privacy restrictions, and then the right for confidential communications. So this, again, is a time-limited waiver when your disaster protocol has been put in place. Recently, the Office of Civil Rights gave guidance, and it's just been in the last week or so, about disclosing information to first responders and to EMS. And they specifically said that you can disclose patient information as a hospital or covered entity for treatment purposes. So that includes physicians. And you can disclose to law enforcement if you have a prisoner that's in your custody or they're in the custody of the law enforcement, you can disclose information, but again, the minimum necessary information that they need. And then if the first responder, if they're helping with treatment or they may be at risk of infection because they're responding to this patient, you can disclose that information. And then they included examples of when you can disclose information to a first responder or an EMS dispatch. And under the HIPAA guidelines, it talks about being able to provide the list of the COVID-19 patients to EMS dispatch so they can use it on a per call basis. However, I do recommend that you please review your state law provisions, because if state law is more restrictive, then you need to follow state law. Whatever's more restrictive to protect the patient controls. And some states require covered entities to report the list to the Department of Public Health, and the Department of Public Health then discloses that to EMS dispatch versus directly from the covered entity. So again, while there is a HIPAA permissible guidance from OCR about notifying first responders and EMS dispatch, it is important that it be minimum necessary, hopefully on a per call basis. And if you're going to disclose the list, please look at your state laws to determine if it needs to go through the Department of Public Health first. So that was a quick overview of EMTALA still applies and HIPAA still applies. And now I'm going to transfer it to Bob Threlkeld to talk about the numerous waivers that we've received as healthcare providers over this last week.
Hey, Bob, I think you're on mute.
Oh, terrific. Thank you, Elliot. I was on mute. Sorry about that, everyone. So there were waivers issued this week, both by CMS with respect to hospital conditions of participation, as well as Stark Law waivers and a number of other waivers. And then there were waivers that Georgia has sought, and some of which were granted on April 1st under Section 1135 of the Act from CMS. The waiver requests were submitted by the Georgia Department of Community Health to CMS on March 27th. 2020. Blanket waivers came out from CMS on March 30th, and then the Georgia waiver application was approved on April 1st. Many of the requested waivers were duplicative of the blanket waivers from CMS. Other waiver requests are not prohibited or not duplicative. So in terms of what was approved, first, the requirement was suspended to get pre-authorization and existing of pre-authorization to treat Medicaid patients. Second, suspended pre-admission screening requirements for long-term care providers. Third, there was an extension of fair hearing deadlines for denials of care for Medicaid beneficiaries. Fourth, there was a waiver put in place for temporary providers. And then fifth, waivers of care for provision of care in temporary settings. And there are a few more outstanding waivers that Georgia has requested that I anticipate CMS will likely approve in short order. So then on Tuesday of this week, CMS issued broad waivers for temporary actions relating to the COVID-19 emergency. The actions are going to allow providers to temporarily increase hospital capacity, and Elliot's going to talk about that in terms of the ability to do that in Georgia under the suspension of the Georgia CON law, a waiver of Stark law requirements, promotion of telehealth, importantly, relaxation of supervision requirements for residents, providing care, relaxation of supervision requirements in other contexts, relaxation of inpatient rehab rules, and ability to rapidly expand the healthcare workforce. So first and foremost was the waiver to increase the hospital's licensed capacity. And CMS is doing a variety of things in this context. First, it's allowing hospitals to provide and bill for hospital services, which would be under arrangements in very unique circumstances at off-campus locations, such as community sites or hotels or other sites. Secondly, conditions of participation are being waived so that you don't have to meet the architectural and physical environmental standards for hospital buildings and spaces, including spaces that would house inpatient beds. Third, hospitals are going to be able to operate certain off-campus buildings as provider-based, which otherwise is no longer permissible. And lastly, and interestingly, allows ambulatory surgery centers to be able to temporarily enroll as hospitals to address patient surges. So in terms of the Stark law waivers, CMS did issue significant waivers of the Stark law that govern financial relationships between physicians and hospitals, solely related to the COVID-19 emergency, provided that a couple of matters are met or encompassed. First is that all remuneration no longer needs to be fair market value. Rental charges no longer need to be necessarily fair market value. Remuneration no longer necessarily needs to be fair market value. And remuneration in terms of medical staff benefits that can be greater than the incidental benefits that are otherwise available. But look, there's real limitations on this. And so when we think about what is the analytical framework to engage in these waivers, I break it down to a four-part analysis. First, does the conduct relate solely to the emergency period? Second, is the remuneration between a hospital and a physician or physician organization or an immediate family member? And third, the remuneration and referrals can solely relate to COVID-19 purposes, which is key. And fourth, if so, providers can rely on a Stark exception if they cannot meet one or more of the waiver requirements. And so fundamental to all of this is whether the Stark law waiver is for a COVID-19 purposes. And CMS outlines 6 COVID-19 purposes, all of which are kind of related. One is the diagnosis or treatment of COVID-19 for any patient or individual. Secondly is securing the services of healthcare providers to furnish clinical care in response to the COVID-19 outbreak in the United States. Third is ensuring the ability of healthcare providers to address patient and community needs due to the COVID-19 outbreak. Fourth would be to expand the capacity of healthcare providers to provide care during the outbreak. Fifth would be to shift the care, clinical care to patients to appropriate alternative settings due to the COVID-19 outbreak. And sixth, and this is a very important one, is to address medical practice or business interruption due to the COVID-19 outbreak in the United States in order to maintain the availability of medical care and related services for patients. Now you can go on the CMS website and they've got 19 or so illustrative examples of conduct that can be waived. They do not specifically address the issue of continued payment to employed or contracted physicians whose volume of patients may have dropped dramatically during the COVID-19 outbreak. I think that's an important question. It's a complicated one on a case-by-case basis, but I would say generally, providers should bear 2 things in mind. Whatever you do in connection with this has to be commercially reasonable. In other words, does it make sense from a business standpoint? And number 2, whatever you do has to be available to everyone in the same class. So if you're going to do something for one class of employed physicians, do the same for all other employed physicians. Same thing for contracted physicians, same thing for medical staff members. And 3, avoid any sort of conduct which would raise general concerns of fraud and abuse. So the waiver is going to allow hospitals to pay extra hazards, rent space to accommodate patients, to provide PPE and equipment below fair market value, and to provide medical staff meals and change of clothes, but also a wider degree of things, including support of the medical staff, as I mentioned. Quickly, CMS is also relaxing requirements for residents and teaching physicians. They're going to allow a teaching physician to supervise medical residents through interactive technologies and be present through those interactive technologies for the key portion of a service. CMS is also allowing any level of E&M service to be provided by a resident in a primary care exception location, as long as the teaching physician is also available through technology. And then CMS is increasing flexibility for residents to provide telehealth services, including through moonlighting. Resident services such as telehealth and interpretive services can be provided in the resident's or patient's home, and they can be counted for IME and DGME payment purposes. Teaching physicians, however, still must be present during the provision of anesthesia, surgery, or high-risk procedures, which makes sense. There's also changes to requirements for supervision level for therapeutic services, reducing it to general supervision, so physician no longer required to be on site at any point during such therapy. And those services are all hospital outpatient therapeutic services that fall under that regulation there. There's also waivers of certain paperwork requirements. So third bullet point, that's an interesting one. CMS is waiving the entire utilization review condition of participation, which otherwise requires the hospital to have a UR plan with a UR committee that's going to review services furnished to governmental patients to evaluate medical necessity. So that is waived as a condition of participation during the COVID-19 emergency. Also importantly, nursing staff are not necessarily required to develop and keep a current nursing plan for each patient, although in most cases it's going to make sense to continue to do that. And then the other waivers are listed there. With respect to surge facilities only, CMS is waiving the requirement to have written policies and procedures for staff to use when evaluating emergencies. CMS is also waiving certain medical staff requirements to expand the workforce. So they're going to allow for physicians whose privileges would expire to continue practicing at the hospital, and for new physicians to be able to practice before the full medical staff or credentialing committee can give appropriate review and approval under the medical staff bylaws. Medicare patients may be assigned to non-physician clinical staff as appropriate. CRNA supervision is going to be allowed at the discretion of the hospital or an ambulatory surgery center, and hospitals do not have to designate in writing who's going to be qualified to provide respiratory care procedures. And so for critical access hospitals, CMS is also waiving minimum personnel qualifications for nurse practitioners and PAs. They're still going to need to meet state requirements for licensure, but not federal requirements that could be above and beyond state requirements. And for critical access hospitals, CMS is now going to defer to state licensure, certification, and registration for state law purposes. Also importantly, a waiver of any national coverage determination or local coverage determination that have face-to-face requirements that are not imposed by statute. Those requirements may be waived. Those requirements, when required by statute, can be met through telehealth. There's also some inpatient rehab changes. CMS is relaxing rules that would otherwise require 60% of patients admitted to meet the CMS 13 guidelines. Patients can still be treated if the record documents that the patient was admitted because of the COVID-19 emergency conditions. Telehealth can be performed by physicians. So in inpatient rehab, you've got a requirement of 3 physician visits a week per patient. You can do that now via telehealth, and they're waiving the requirement for a physician to screen the patient post-admission within 24 hours for medical necessity, as long as the pre-admission screening is properly done. So that is a short summary of a vast amount of waivers that the government, both at the federal and state level, has made in response to the emergency. So now I'm going to turn it over to Elliot, who's going to talk to us first about telehealth.
All right. Thanks, Bob. Please excuse any neighborhood background noises that I can't seem to escape. So the first thing I think CMS and Congress are trying to push with telehealth and really trying to encourage providers to take advantage of is the use of telehealth in as many settings as possible. And the stated goal of that is both to protect vulnerable populations, so your cancer patients, your babies in the NICU, but also to protect physicians, because as we know, there are a quite limited number of physicians, and to the extent that they get sick, we lose more of our physician workforce. So with that said, CMS has gone through 2 rounds of telehealth rules. The first was in the middle of March, and that rule, which was initially instigated by Congress, allows Medicare payment for telehealth really nationwide, so waives the rural area requirement. That rule also waived the requirement that a patient be at a Medicare designated originating site. So specifically there, a patient can be at their home and receive telehealth. CMS also waived certain requirements around approved technology. So previously, where you would have to be using an approved HIPAA compliant platform, CMS is now allowing for use of anything that has a two-way audio-visual connection. So Skype, tablets, FaceTime, that sort of thing. In the second round of rules, CMS issued huge new rules expanding the provision of telehealth, but also something that really is going to expand payment to hospitals. So CMS is allowing telehealth to be billed as though it were face-to-face. CMS also issued a expanded list of services that it will cover for telehealth, and notably that includes emergency department, it includes initial inpatient, and it includes areas like the NICU and certain radiation therapy management sites of service. It also reduces, previously there was a restriction on how often you could use telehealth for subsequent hospital visits. That has now been, that restriction has been gotten rid of. So you can use telehealth really for any site of service in the hospital. And you can do that even with the physician sitting in their office or in their home. Again, the purpose of this is that CMS is trying to preserve the health of the physician workforce to be able to address this crisis. For outpatient or office E&M services, CMS is saying that the level of service may be selected based on time rather than medical decision making, so you don't have to document a physical exam or history. CMS is expanding access to virtual check-ins to allow those to be provided to new patients. They're also, in some cases, allowing limited reimbursement for just telephone services provided to patients. These would be 5 to 10 minute check-ins with patients. Finally, CMS is expanding direct supervision guidelines to allow for direct supervision to occur through telehealth. So that would be direct supervision for things like drug infusion, diagnostic testing, and hospital therapeutic services where you see the regulatory definition of direct supervision required. That can be provided through telehealth. CMS has also, and we'll get to this with the physician licensure aspect as well, but CMS is allowing physicians to be licensed to practice in a state in which they're not licensed. In general, for telehealth, even though it's remote, physicians have to be licensed in the state where they're providing those services, or in a state like Georgia, they can have the new special telehealth license. CMS is waiving those requirements, and Georgia has issued commensurate waivers insofar as it will grant emergency permits. Governor Kemp in Georgia has directed the medical board to issue rules waiving certain medical board requirements around telemedicine. We are still waiting for those, and I believe the medical board has a remote monthly meeting sometime this week. Michelle talked about HIPAA with telemedicine, but this is just going back to the idea that we don't have to have certain HIPAA compliant telemedicine platforms. We can use things like FaceTime and Skype. We should not be using platforms like Facebook Live, TikTok, Snapchat, or platforms like that. Briefly, as the licensure and scope of practice, like I said, CMS has waived certain requirements regarding state licensure. So physicians can practice or go across state lines to practice as needed if they meet these 4 conditions. This, again, will depend on state law. So state law still rules licensure aspects. Georgia is allowing for emergency licensure, the application on the medical board website. I believe around us, South Carolina has allowed for cross-state line licensure, and many other states have done so as well. Georgia is also allowing certain temporary licenses for nurses. Those are available on the Board of Nursing website. With respect to nurses, Georgia will be allowing nurse trainees and graduate nursing programs to obtain temporary licenses and work under supervision. Georgia will also be allowing retired physicians to come back and practice, provided that those licensees were not subject to investigation at the time of expiration of their licenses. We would remind hospitals to consider their insurance requirements for physicians, like retired physicians. Malpractice insurance may be a consideration there. GHA is working on language with the government to provide immunity, but that is under review. We also have a exemption for prescribing medicine via telehealth. These, you may prescribe medicine to patients that you haven't seen. I think we would recommend caution here. So prescribing antibiotics for an ear infection may be one thing. We would exercise caution with prescribing opioids to patients that you haven't seen. Quickly, Brian Kemp waived OCGA 31-6-40 as it pertains to this crisis. So facilities can do things like quickly expand capacity or spend more than the $10 million that would usually require a certificate of need. Rather than completely suspend the statute, though, the Department of Community Health is asking facilities pursuing these actions to go onto the DCH website and complete just a little 2-page application that is both a form of notice, so DCH can track this, and permission, but we expect that permission to be granted quickly. I'm not going to spend much time on fraud and abuse, but would remind providers that the government is asking providers to report anything that seems like a scam, someone trying to take advantage of the situation. So any businesses selling any crazy cures for COVID-19 online, or price gouging, or other fraudulent practices. And with that, I will turn it over to George to talk about SBA loans.
Great. Thank you, Elliot, and good afternoon, everyone. So I want to first begin by just speaking briefly on the CARES Act and some things that came out just beyond the kind of SBA loans. So first of all, CARES Act did allot $100 billion that we anticipate will go to healthcare institutions, healthcare providers. We anticipate that these will go for things to cover the losses that are caused by the pandemic, as well as the additional cost that will be spent with facilities, additional workforce, additional supply costs, and those types of things. The CARES Act also expanded the ability for Medicare to pay accelerated payments. There are some eligibility requirements around these, not too stringent, but you have to have been enrolled with Medicare for 180 days prior to requesting the accelerated payment. You may not be in bankruptcy, and you may not be under active medical review or program integrity investigation. And you may also not have any outstanding Medicare payments that are due. Now, in terms of the accelerated payments, most providers and suppliers are eligible to request up to a 100% payment. For many providers, this can be extended for a period of 3 months. Our hospital providers, they can request up to 6 months. And I would also say that the critical access hospitals are permitted to request up to 125% of the payment amount. Now, in terms of the repayment around the accelerated Medicare payments, these are not set to begin for 120 days. For hospitals, the entire amount is not required to be repaid for an entire year. For most other providers and suppliers, you will have 210 days before the full amount of the accelerated Medicare payments is required to be repaid. Now, moving on to the SBA loans, these, and I want to first address sort of the economic injury disaster loans, or the EIDLs. These have been available for some time to address various disasters. Many of them, it was primarily intended to address natural disasters. The CARES Act expanded the availability of these loans to address this very unusual sort of pandemic we are experiencing now. In terms of what may be requested, if you are applying for an EIDL loan, you are eligible to receive up to $2 million for a period not to exceed 30 years, and that will be done sort of through the underwriting process. In terms of interest rates, these will be for eligible small businesses, these will be 3.75%. For the nonprofits who are actually just able to apply for these loans, the interest rates will actually be 2.75%. Now, an additional aspect that was added through the CARES Act is the ability to obtain a $10,000 grant. Now, the grant is something that may be obtained, but it does not have to be repaid if you do not receive the loan. This can be used for various purposes, including payroll, sick pay, and things of that nature. Now, I also want to speak a little bit about the purposes of these EIDL loans. As we will see in a moment, some of the loans that are being made under the Payment Protection Program have a much narrower scope. These loans can actually be used, the EIDLs can actually be used for working capital, operating expenses, and other harm that is caused by the disaster. There are limitations around these, and those would include you are not able to use them to pay dividends or to make facility expansions, but again, they do have a broader purpose than the ones under the Paycheck Protection Program. Now, the Paycheck Protection Program, again, this is something just new that was passed as part of the CARES Act. And it allows eligible businesses, which I will speak about in a moment, to obtain loans up to 2.5 times your average monthly payroll cost, subject to a maximum amount of $10 million. Now, I want to focus and break down on the payroll costs just for a minute. The payroll costs include things beyond just compensation and salary. These can include medical and sick leave, as well as the cost of benefits. Now, there is, and I'm sure as many of you are aware, there is a $100,000 cap with respect to the salary amounts for people who make over $100,000. So when you are calculating your payroll cost to come up with your total eligible loan amount, you would exclude the salary that is attributable to the excess over $100,000 for those that make in excess of that amount. Now, in terms of interest rates here, it's, the Act actually allows for an interest rate up to 4%. What came out in the interim guidelines last night, it's actually limited to an amount of 1%. So if you're applying for a loan today, that's the interest rate you will pay. Now, these loans will mature in 2 years. The Act allows them to mature in a period of 10, but in the interim guidance we received, the administrator is going to limit the terms to 2 years currently. The payments under these loans are actually limited, they will be deferred for a period of 6 months. So while interest will continue to accrue on loans, no payments will be due under them for a period of 6 months. Now, I also want to focus just for a moment on the uses as what they, the uses of these loans, what they can be used for. Here, it's very restricted. Unlike the EIDLs, there are restricted uses around these funds. The restricted uses include the payroll costs, which again, these can be salary, it can be benefits, medical and sick leave. These can also be used to cover certain interest payments, including mortgage interest. I would say here, though, they cannot be used to cover your mortgage, your principal mortgage payment. It must be just used to cover interest. They can be used to cover rental payments and utility payments. Now, another aspect of these loans is the forgiveness. And this is unusual, and unlike the EIDLs, these may actually be forgiven in full. Now, they have said, the government has come out and said only 75% will, or pardon me, let me say that, only 25% will be forgiven in terms of non-payroll expenses. So things such as rent, interest payments, these will be limited to 25%. Now, the rest, if you use this exclusively for payroll expenses, those will be fully forgivable. Now, another question that has come up from several of our healthcare clients that I want to address is, may we apply for both an EIDL loan as well as a PPP loan? And the answer to that is yes, if the loan proceeds are used for different things. So for instance, if I obtain a Paycheck Protection Program loan for purposes of paying payroll, covering payroll expenses, and then I obtain an EIDL loan to cover more operating expenses or my working capital needs, that would be acceptable. But I could not obtain both loans to cover, let's say, payroll expenses in this instance. And here we have the remainder of the slides are just dedicated. We've tried to break out for you the difference between these various loans and the various terms. Michelle, at this point, there's no reason for me to cover those, but I will turn it back over to you. But I would remind everyone on the call, if you are interested in looking at a side-by-side comparison, that is included in the remainder of the slides.
Thank you, George, and thank you for going through the financial side. I know that's been a key issue for a lot of the individuals that are on the line today. We do have a couple of questions that we are going to respond to, and then I also wanted to share before we get to the questions some additional resources that you have through links that we've included as resources at the end of these slides that includes different explanations of the waivers that are available, as well as some documentation and forms that are readily available to assist you as you're moving forward with either the suspension of the CON or addressing the Stark waivers. And so to get to our questions, Bob, I think I'd like to start with you if it's okay. We have a question related to the waivers for freestanding rehabilitation facilities. And can you share more information about how that would work on an under arrangement and then the waiver provisions related to freestanding rehab?
Yeah, sure. Can you hear me, Michelle?
I can.
All right. That sounds good. So the CMS has said that a freestanding rehabilitation hospital can work with acute care hospitals under arrangements to provide surge capacity for the community. And so typically what that would mean is that you are providing service on behalf of the acute care hospital and should be able to be reimbursed directly or indirectly for the provision of those services. And the way I read that, I do think that that means acute care patients. The question that I think is more subtle is to whom can you provide these services under arrangements? If you, an under arrangement typically would need to be done within 35 miles under the Medicare rules. The question is if a hospital is more remote than 35 miles, can it be done under arrangement? I think that is a question that that we would need to provide further guidance on, and I'd be happy to follow up via email on that issue. And then the other question is, could a hospital provide freestanding rehab hospital provide something under arrangements when you would not otherwise typically meet the under arrangement requirements, which would include a common governing body and an integrated financial and clinical processes? And I think the answer to that is yes. And again, that is a complicated question as to how you would do that with unaffiliated hospitals, but I think the answer is yes, and I'm happy to provide further follow-up on that via email.
Thank you, Bob. And then, Elliot, we have a question with regard to the telemedicine waivers. And the question is, when the public emergency ends, can you continue to use FaceTime and for it to continue to be reimbursable by using FaceTime or Skype for telemedicine?
So no, you can't. The telemedicine waivers and rules are limited to the duration of the public health emergency.
Okay, thank you. We also had a question regarding rural health clinics and federally qualified health centers who have always been able to bill for telehealth services. And one question is whether or not, and I'm happy to respond to this, whether or not remote patient monitoring can be billed for. We have not seen a full waiver of that related to the rural health clinics and the federally qualified health centers, but there is an extension of discussion in the rule that came out on Tuesday that relates to remote patient monitoring and the expansion and the support of remote patient monitoring. So we're watching to see where the reimbursement policies may move forward with those initiatives. And then, George, we have a question about the emergency loans, and I know you talked about the cost and how you can only use it for one purpose different from the payroll payment, the Paycheck Protection Act. The question is what kinds of things can you use the emergency disaster loan for if you were to obtain that and the PPP? Of course, you have to have fewer than 500 employees, but can you share some of the things that can be covered by the disaster loan?
Sure, Michelle, happy to do that. So the disaster loan can be things like your operating expenses. You can also cover your payroll through this. Now, again, as I mentioned, you would not be able to use them simultaneously for that, but you could use that if you were to exclusively obtain an EIDL, you could use that for the payroll. You can also use this to cover things like disaster-related supplies and additional expenses related to your workforce in this time. Michelle, did that answer the question?
It did. Thank you, George. And that does, we just want to remind everybody, you always got to make sure you've got two different uses on those two different programs, the SBA loan for payroll protection and then the disaster loan. And so this does bring us to the close of the hour. There are a couple of additional questions that we have, and what we're going to do is provide a response to those in writing, and we'll share that with the slides for everyone who participated today. I've got a couple of questions of how do I get copies of the slides, so we'll make sure we send that out to everyone who participated today. We thank you for joining us. We are doing a series of webinars, and again, that slide that at the beginning that had the information about our resource page has a lot of information there that helps both healthcare providers and then other industries that are also dealing with this pandemic as we move forward. So thank you all for joining us on a Friday afternoon, and we appreciate your time today. Thank you.
Thank you, Michelle.